15 minutes, Ms. Sara DiTursi will familiarize us with the roles and interventions of the infectious diseases pharmacist. She completed her Doctor of Pharmacy degree at the University of Buffalo, and she completed her pharmacy practice residency at the Buffalo Veterans Affairs Medical Center, where she also works currently. Sara, you have our attention.
Thank you, everyone. Thank you for the introduction, Katerina. So, as Katerina mentioned, today I'm going to be talking about what is the role of the infectious diseases pharmacist, and what are interventions that the pharmacist can make as a part of a multidisciplinary team. So I just wanted to start off by giving a background of the hospital that I'm currently working at. So the Buffalo Veterans Affairs Medical Center is a federal hospital that's owned by the United States government, and our patients consist of veterans who have served in active war duties. And we're also affiliated with the University at Buffalo. We have about 150 inpatient beds, as well as 50 nursing home or rehabilitation beds. And we have quite a few different mental health services, including inpatient and outpatient psychiatry. We also see a lot of outpatients at our facility. This includes primary care clinics and also specialty clinics. So our patient population is somewhat unique in that our patients are largely older male veterans, but nowadays we're seeing more female and younger veterans as well. So with the advent of antimicrobial resistance, this is really a good time for pharmacists to become involved in antimicrobial stewardship and really being part of the multidisciplinary team. This was a culture from a patient that we saw recently that has 2 very resistant organisms. So this is definitely an area that pharmacists can become involved in. And throughout my presentation, I'll be talking about a wide variety of areas that we're involved in at my hospital. So I wanted to talk about, firstly, the specialized training that's available in the United States. So currently, I'm a second-year resident who's studying infectious diseases pharmacy at the hospital. And this program is done after completing the Doctor of Pharmacy program, which is the required degree currently in the United States. And then a person can go on to complete the first-year general residency, and then they can choose to pursue a specialty. So at my hospital, we currently have 2 infectious diseases pharmacists. One mostly focuses on our inpatients and antimicrobial stewardship, whereas the second one largely focuses on hepatitis C as well as HIV. Then we have the pharmacy resident who's in training, which is my current position. So I wanted to start off with talking about antimicrobial stewardship, which is a really big area that pharmacists can become involved in and make a great impact. So something that's quite unique about our hospital is that we're owned by the federal government. So the normal laws don't apply. Usually these laws are done by the state. Can you guys see me on the camera now? Just want to check if you guys can see me. Sorry guys, not sure why. Oh, start sharing. Here we go. Sorry about that, guys. So to continue here with antimicrobial stewardship, our pharmacists are actually considered providers if they have specialized training. So we're able to order things such as laboratory values, drug levels, antibiotics, as well as cultures, independent of a physician or provider. So this is definitely something that's unique to our federal hospitals. Our stewardship model currently consists of printing a list that has a list of all the patients that are currently on IV antibiotics in our hospital. So what we do is we write progress notes in the chart for any patients that were admitted that are new to antibiotics, if they require specialized dosing, or if they need some sort of follow-up or change in therapy. We follow and write notes on an average of 50 patients per day in this service. And as I mentioned, our hospital is a teaching facility where we have a lot of trainee physicians and other providers. So we have an opportunity to learn alongside them as well and participate in a variety of services, whether it be the medicine service, our surgery services, or our intensive care units. So our progress notes will make recommendations to the provider. We'll also usually call the provider as well with our recommendations. And these include things like de-escalating antibiotics, or something that we might not normally think of, which would be escalating antibiotics, whether it be based on cultures or if the patient is not getting better on the current therapy. We also make recommendations regarding dosing, which we can actually change ourselves in the electronic medical record, monitoring drug levels, and also doing things such as managing adverse effects of these antibiotics. We also have antibiotics at our hospital that are restricted. That is, they have to be approved by either the ID pharmacist or the ID physician. So this is a great role that we have in our hospital, is that we're able to approve these restricted antibiotics. So we're able to, approve them. And this is a list of a couple of the antibiotics that are restricted at our hospital. Some of our more broad spectrum agents are those that might have more adverse effects associated with them. So we're able to approve them and monitor the patient closely if it's warranted. Hope you guys can see this, but this is an example of a progress note that we enter into the patient chart. So this was for a patient that was on 2 antibiotics that we were monitoring levels for. We were also following up on his cultures. And down in the assessment section, this is the important section where we kind of analyze what's going on with the patient, and then the recommendations from a pharmacy perspective, which in this case was to change how his antibiotic was being dosed based on the levels that we had ordered and monitored. This graph just shows really how well our stewardship program has done. So we keep track of what recommendations we make to providers, and then we also keep track of if that recommendation was accepted. So as you can see, for the most recent data that we have in 2017, there were quite a few categories where we had 100% acceptance by providers. So I would say at our institution, the physicians and other providers are very open to our recommendations, especially with a lot of our trainee physicians. They're wanting to learn more. They may not necessarily know every detail about every antibiotic. So this is definitely a way that we can improve patient care. We also have been able, through our stewardship program, to decrease the cost that we spend on antibiotics. As you can see here, we have the data from before we had a stewardship program, when our program was just getting started. And now that we've had this program for about 5 or 6 years, how the costs have decreased in our antibiotic spending. So our pharmacy managers, are really pleased to see that we're making interventions and we're spending less on antibiotics in general. This also shows not only from a cost perspective, but from a patient perspective. This shows antibiotic doses per 100 patient days. So as we can see, going from the pre-stewardship era up to 2017, we're decreasing how many doses patients receive, looking at it through 1,000 patient days. So again, decreasing the antibiotic use, hoping to prevent resistance and prevent any adverse effects that the patient may have, and appropriately treating infections. We are also heavily involved in our outpatient parenteral therapy program, and this is for patients who may need extended courses of IV antibiotics, and they're able to go home with this medication. So as pharmacists, we do a lot of patient education, and we'll consult with the physician that's going to be taking care of them on the treatment plan, and also following up with any laboratory parameters or changes to their therapy, and also documenting this in the record as well. So this is an example of a home antibiotic note that we as pharmacists that I wrote in the chart. And basically, it's a little bit simpler than our inpatient notes. We're mostly following the laboratory monitors and also monitoring them for any adverse effects as well, and making sure they go for labs and are followed up with appropriately. We also work very closely with our colleagues that work in our microbiology lab. We actually go down to our microbiology lab on a daily basis, and this allows us to gain some advanced culture information that can affect which antibiotics we might recommend or de-escalation. We also, our facility is getting a lot of rapid diagnostics within the past year or so. So this has really helped stewardship. Instead of, waiting 2 to 3 days for a culture to be finalized, we're able to get, for example, blood culture results within 90 minutes, which is also changing the way that we're practicing stewardship. And we're just implementing this now, so we're still, getting used to that as well. I also got to spend 2 weeks in the microbiology lab as a part of my program, which was a really great way to see how that lab functions and where we can work with them as well. Our ID pharmacist is also responsible for making the antibiogram. So this helps guide which antibiotics we might use empirically. So I just gave the example of the most recent one that we constructed in January. And this just shows our Pseudomonas sensitivities. The next big component that we're involved in is our infectious diseases consult service. So this service serves patients. So basically, the main doctor that's taking care of the patient while they're in the hospital will request the patient be seen by infectious diseases if it's a particularly complicated patient or infection, just for additional help and recommendations. So this team consists of an attending physician. We might have some learners like an ID fellow or medical resident or student. And the pharmacist rounds daily along with the ID pharmacy resident on these patients. So usually we'll all sit down and discuss the patients and then go see the patients at the bedside. And kind of similar to stewardship, there's really a lot of areas for interventions, and the physicians might turn to pharmacists for questions as well on this service. There's also a lot of learning that goes on this service. Kind of as I mentioned, we have a lot of students and medical residents that are training as well. We also give formal lectures at the pharmacy school. I gave a lecture on Clostridium difficile to our third-year students. So that was really a great learning opportunity and an area that we can also participate in. We also have infectious diseases grand rounds. So this is where all of the departments of infectious diseases in the city of Buffalo get together, and we discuss and present interesting or complex infectious diseases cases. Now we're going to kind of shift from the inpatient side to the outpatient side for roles of the infectious diseases pharmacist. So this picture here on the left was an article that was in our local newspaper that looked at our hepatitis C clinic at our hospital. And this picture here is actually 2 of our pharmacists that participate in the hepatitis C clinic. And then this picture on the right here is our hepatitis C testing day that we had. So we had 3 of us pharmacists participate in that, and we were able to test 24 patients within a couple-hour window, which was really great. And kind of this outreach is another role for pharmacists as well. A little bit more details on our hepatitis C and HIV clinic. So our facility received money from the federal government to treat all veterans possible for hepatitis C, because in the United States, this is one of our high-risk populations for hepatitis C. So we have quite a lot of patients that would require treatment. So the pharmacist that works in this area work very closely with the providers to kind of plan out therapy before we start them, looking for things like drug-drug interactions, maybe some adherence concerns. And then once the patient is ready to start therapy, we counsel the patient on the medication, and we'll also ensure they get the appropriate follow-up labs, and also making sure the patient's adherent with their medication refills, and also ordering the drug, because these are quite expensive specialty drugs. So making sure we keep proper inventory of these as well. This is just an example note that I wrote on a patient that was seen in our hepatitis C clinic. It's just kind of a snippet of the bottom of the note, but basically, summing up the patient, what the plan was, what we looked through, things like drug-drug interactions and vaccinations would be relevant, and also what we discussed with the provider and our plan to start this patient on what treatment and for what duration. And we'll also write follow-up notes as well, in addition to this, which was an initial note. We also serve as members of infection control. So being a part of committee is also a really important part of the role of the infectious diseases pharmacist. So we work with the physicians to manage infectious diseases outbreaks that might occur. For example, a couple weeks ago, we had a flu case on our nursing home floor. So this required all the residents to be prophylaxed with Tamiflu. So this was an example of how we kind of, managed this outbreak. We're also responsible for reviewing a lot of our hospital protocols daily. This might not something that we think of as directly relating to drug therapy, but it's a really important way to educate providers and have these policies in place. So this was an example of our Clostridium difficile protocol. It's going to change a bit now because there's new guidelines, but this was something that we review every year that's available to providers in our hospital administration to see what we're doing as far as recommendations for a patient that's positive for Clostridium difficile. This was another protocol that we created just this year because we had a really bad influenza season here in New York. We created this to alert providers to what medications we have available for treatment of influenza, and also things like adjusting for renal dysfunction, and then doses for treatment versus prophylaxis. And this was something we distributed to all of our providers at our medical center. This was just an example note of our infection control roles. So this was just put in on a patient that had to be prophylaxed due to a positive flu, and another patient on the nursing home ward. And as you can see, they had to be adjusted for their renal function. So we'll actually go ahead and enter and order the Tamiflu kind of as sole providers, which a lot of our providers appreciate, given the number of patients we have on this nursing home floor. So we're really able to act as providers. Another aspect that's really important for us to be involved in would be formulary management. We're active members of our Pharmacy and Therapeutics Committee, which manage which medications we keep on our formulary and also approve other pharmacy-related issues. So this would include things, as I mentioned before, approving restricted antibiotics, managing the formulary related to antimicrobials, and also creating monographs or other protocols. This is an example of a non-formulary note. So certain medications need to undergo review of a pharmacist to be approved. So this was just an example of an ID-related medication where we assessed the patient and decided whether or not the medication would be approved. This is usually if they've failed our first-line agents. But again, properly assessing the patient and the situation and making a determination using our specialized infectious diseases knowledge. This was an example of a monograph that I did as a project for a relatively new hepatitis C medication. This is just part of the monograph, but it describes various things about the drug and its place in therapy. And this can serve as a reference as well to our providers, especially when new medications come out and they may not know everything there is to know about this medication. This can serve as a quick reference that was created by a pharmacist. Something that's pretty unique to our hospital, I would say as well, is our collaboration with our Allergy Service. We have an inpatient allergy service, which is even unique here in New York. And if patients have documented antibiotic allergies, and we're having issues where we really thought that was the best therapy for them, but they have an allergy, we're able to do skin testing in conjunction with our allergy physicians, whether it be on the inpatient side if it's something more acute, or on the outpatient side as well. And this has been really great, and we're able to remove a lot of these allergies from the patient chart, especially down the road if maybe they're sicker and they're requiring other antibiotics. They're able to receive those without concern for an allergy. So this is definitely something that we're still working on, and it's pretty unique to us. And this was just an example of the ID pharmacist documenting an observed allergy or reaction as well. So we'll go through the chart, kind of summarize what happened, and then this becomes a part of the patient record as well. And this is the last section that I'm going to talk about today, and that's outpatient stewardship. So this outpatient stewardship is actually becoming a hot topic right now because we do have various stewardship programs on the inpatient side, but now our government is requiring us to do something on the outpatient side, but we're not really sure quite how to go about this yet. But we started a program within the last couple of months to try to see where our areas for improvement are. So we receive alerts for certain outpatient antibiotics when they're ordered by the provider. And this is in our primary care clinic, emergency department, our specialty clinics, and also our clinics that are in more rural areas that are farther from our medical center, that serve our veterans that live farther away. And what we've been doing is collecting data on the prescription and reviewing the dose, duration, just some basic things using our infectious diseases knowledge, and contacting that provider if necessary. We'll also try to communicate if there's a pharmacist that's working in that area. For example, in the emergency department, we'll try to communicate through them as well, as they might have a better relationship with the provider than we might have directly to kind of facilitate these recommendations. We also are recently starting an outpatient culture review service, and we're mainly trying to involve our first-year pharmacy residents with this project. So what they'll do is, for example, the patient went to the emergency room, had a culture done, was given an antibiotic, and then they're sent home. The culture may not come back for a few days. So we're trying to follow up on these cultures, particularly if perhaps the antibiotic they were given was not appropriate based on the culture. So this is a very new program for us too, so we still got some things to work out with that, but I think the outpatient setting will also become an increased role for the infectious diseases pharmacist to be heavily involved in, especially given the amount of antimicrobial resistance that we're seeing, even in the outpatient setting. And lastly, this was just an example of a template that we made for outpatient stewardship, specifically patients who have bacteria in their urine, but they're not having any symptoms. Typically, in most cases, this is not recommended to be treated. So this is kind of something that we hopefully in the future want to alert providers to, and would definitely be an area of intervention, trying to decrease inappropriate antibiotic use. And that is it for my presentation, and I'd be happy to answer any questions that you may have at this time.
Thank you, Sarah, for your presentation. And while we're waiting for the questions from the participants, I had a question actually. So we've seen a table in which you've compared the costs, how they decreased with the residency program, but do you have any table comparing the outcomes of the patients?
So we don't have one specifically right now as far as outcomes, but we are heavily involved in various research projects. For example, my project last year was looking at treatment of urinary tract infections specifically, and we did note that with the implementation of a stewardship program, we are seeing less patients readmitted for UTIs. If they had been, discharged, been in the hospital for a UTI, were discharged and then readmitted. And we do have other projects that other of our colleagues have done in the past, and most of them showed that as far as patient outcomes, we find that stewardship is very beneficial to patient outcomes as well.
Thank you. That's great to hear. So we have a question from Giovanni. He says that this is a great topic, but that a lot of data analysis was vague to him. So what are the keywords of this kind of data analysis so we can read about it?
Sure. So I didn't have, time to go through all the specifics of a lot of our data analysis, but I would say stewardship is really the main word that I think of in researching more about it, and kind of looking at stewardship, how it reduces costs, how it reduces adverse drug effects, how it reduces admissions or readmissions to the hospital. But I'd say really looking into antimicrobial stewardship would really provide you with more information on the topic and how we as pharmacists can impact patient care in a positive way.
Great, thank you. I hope that answers Giovanni's question. Thank you once again, Sara, for the lecture, and I hope you had fun with us.
Thank you. Thanks for having me.